Okay, we're back. We have Chris Joyce, Steve George, and unfortunately, we just lost Jason Benachek. We spent the last 20 minutes trying to finagle audio, video, connection, and we had to take one individual out. Steve's on the line. He may or may not stay with us because of his audio quality. But thank you, Chris and Steve, for coming on. And before we kind of roll into the topic, we'll start with Chris. Can you just give kind of a little intro and background on yourself, and then we'll bump over to Steve?
Sure. Hi. Thanks for having me, Chris. My name's Chris Joyce. I'm a physical therapist and an assistant professor in the School of Physical Therapy at the Massachusetts College of Pharmacy and Health Sciences. My research background is in musculoskeletal pain and exercise. And I teach courses in evidence-based practice, pain, modalities, and exercise.
Steve, how about yourself?
Hi, yeah, my name's Steve George. I'm at Duke University. I do research in musculoskeletal pain. Also, had the pleasure of crossing paths with Chris during the Target trial. That's where we met, and have enjoyed talking with him about some of his thoughts, outside of this paper, but also related to this paper. So, looking forward to contributing to the conversation.
So the paper that we're going to discuss, the three authors were you two and Jason. So this was published recently within the past few months, the concerns on the science and practice of a movement system. And this was out of the PT and Rehab Journal. So let's start. Chris, do you want to discuss what is a movement system and maybe why the three of y'all decided to collaborate and write this?
Sure, yeah. So the definition of the movement system from the American Physical Therapy Association is, and I'm reading it here so I don't mess it up. The movement system is a term used to represent the collection of systems, in parentheses, cardiovascular, pulmonary, endocrine, integumentary, nervous, and musculoskeletal, that interact to move the body or its component parts. And I guess some of the background of this paper, the movement system is not new to PT, and it stems from these great discussions from some thought leaders about creating an identity in physical therapy and wanting to embrace movement as a critical and core component of our identity and use movement as our, predominant form of an intervention. And subsequently turned into the development of a classification or taxonomy system that purports or proposes movement diagnoses ascribed to movement impairments that physical therapists will make to try to deliver or to try to guide the care that they provide. And really, that that next step is where we kind of got our guard up or got our hair up, and the development of the classification system and the concept of a movement diagnosis kind of alarmed us a little bit in different ways, and that's what led to writing this paper.
Yeah, so this paper kind of chips away at what are the logical steps that would have to occur for a movement diagnosis and subsequent treatment plan of care involving that diagnosis to be kind of clinically valid and recommended. So you all, at the beginning of the paper, you kind of start with the section is key clinical and psychometric properties of movement diagnosis. You actually kind of discuss and frame a lot of these example to begin with from the Academy of Neurological Physical Therapy. Chris, do you want to discuss why you decided to use the kind of a neuro biased example to start for, I'm assuming, a lot of readers that will be on kind of the orthopedic and sports side?
Yeah, it's a very simple answer. The journal made us. We originally wrote the example using knee valgus, and rightly so, the journal pushed back and said it would be better and broader and more generalizable if you could use a neuro example. And I think it was originally, gave me um, cause for concern a little bit because I felt like I was out of my lane there, but I think it was a great suggestion by the journal. And so that's the route that we had to take, which required a lot of background learning and um, understanding.
Totally. The uh, I guess within this, the academy, there's one of 10 proposed movement diagnoses, and you all stay with this deficits in steady state postural control, verticality, as what you decide to elaborate on and look at as a movement diagnosis. So, Chris, do you want to discuss why you chose verticality? And then we can go kind of piece by piece on looking at a specific movement diagnosis and what we would have to consider when viewing it as beneficial or not.
Sure. Yeah. So I want to preface it by saying that I'm not comfortable talking about neurological conditions or impairments, but I'm going to try to do my best not to misspeak or mischaracterize this paper and the work of the authors. But as you said, the Academy of Neurological Physical Therapy published this paper looking at a movement system diagnoses for a balance dysfunction. So this is under the outcome would be balance, and then the diagnoses uh, that they're writing about, as you mentioned, there's 10 of them, and one of them is this idea of verticality. And we didn't select verticality for any other reason over any of the other ones. It was just one of the impairments that we chose to focus on. Verticality, as I understand it, is the ability of the person to orient themselves relative to gravity. And it certainly makes sense that a deficit in one's ability to orient themselves to gravity would lead to balance. So it was kind of like a logical place to start, and it made good sense to me, again, at a very superficial level. So that was why we chose that and ran with it for our example.
So staying with this verticality example, you then discuss if there's going to be this movement diagnosis, there has to be a relevance to this something, whether it's the pathology, a specific activity limitation, or participation restriction. That obviously makes a lot of sense. It should be relevant to something. Is there anything either of y'all want to elaborate on the relevance piece, or should we kind of go into validation and more of the other methods?
No, I think that's, I guess the one caveat that we kind of gloss, I think we mentioned it slightly in the paper, is that verticality needs to be reliably measured. So there needs to be established reliability of the construct of verticality, and then subsequently the clinical relevance pieces, which I think we'll talk about next. Yeah, Steve, go ahead.
Yeah, and I'll just add, I think, and Chris, I think did a nice job at, letting folks know we're not neurologic physical therapists. Hell, I'm not even a clinician these days most of the time. So, it may seem like we're picking on this, but it really is just one example. I think there's several, across neuro and musculoskeletal. And as Chris mentioned, I think the ask from the journal reviewers was to make this a little bit more broader because it might, hit a little bit more. But I think there's a lot of things where the relevance beyond does it deviate from some norm that we have created either culturally as a profession or what we see a lot in what is quote unquote normal activity. It's really pushing, is there something beyond just, does it deviate from a perpendicular line that we can draw or do with a plumb line, and if it does, is that relevant to risk? Is that relevant to pathology? Is that relevant to clinical outcome? And, when you start moving away from, can we just observe it as being, varying from the perfect straight line, and asking these relevance questions, it's not just verticality. There's a lot of tests that are like that. But these are the questions that we need, I think, to understand clinical decision making, patient management, and whether people are really benefiting from assessment and treatment driven around these things. So I know we're going to go through a little bit more of the validation, but that's really, to me, um, the appreciation of how the variability around that normal, that which, by the way, we created, I think, as a profession. There are some obvious benefits to remaining vertical. I'm not disputing that, but what that range of acceptable ways of staying vertical, I would hate to think it's just 90 degrees, to the horizontal. So I think that's where the relevance comes in my mind broadly, is what are those ranges where it really does become relevant. And I don't think it's like at 89 and 91 degrees, if you're 1 degree one way or the other. And there could be a lot of reasons for that. Could be measurement error, could just be that's the range of norm that we expect. So sorry, that was a little convoluted way to say we're picking on verticality because we had to pick one. I mean, there was a word limit, but this is a broad issue with many of the tests, and especially those related to the movement system. So that's I think another kind of a big point.
Yeah, and if you all feel more comfortable switching out of verticality, discussing more of these topics with either prognosis or validity or any of these, it's totally.
No. And I think, I reread the paper before because it seemed like a good idea. What I like about the verticality example is it shows what could be done with verticality. Whereas I think with the musculoskeletal examples, we tend to focus on what hasn't been done, or what has been done and suggest you shouldn't be using this. I think what was nice is Chris did the back work on this and laid out a nice kind of, well, how do you, if you really want to make this relevant, there's a playbook right there. And Chris can talk through, I think, because he was, I would say, passionate about this part of, do we know this about verticality? And you don't even need to know all of them. It's like knowing some of these, knowing the known groups, knowing whether it's predictive. And I think he shows ways to do that. So I'll just pass it over to him if he wants to, talk a little bit about specifics of those. But that's why I like the verticality example in the paper, because it's like, well, if you would want to explore the relevance part, here's how to do it.
Yeah, and I think exploring that relevance, it doesn't necessarily have to precede the the conceptual background and the vision of creating this movement system. Like, we're not saying that these things have to occur, these things that we'll talk about next have to occur before any movement can be done. But before we go through this massive widespread implementation and adoption of this framework, certainly some of it should be considered, and there should be some evidence. And in as far as I know, which is limited in terms of the verticality, it hasn't been done. But then when we looked at the musculoskeletal literature, a lot of it has been done, and the evidence for supporting these movement diagnoses isn't very compelling at all. And so there's just a lot of work that needs to be done before we implement and adopt this gigantic identity and framework. So yeah.
So some of the work that would have to be done is what you dive into for verticality of, let's just start with known group validation. What does that mean, and what would that tell us?
Yeah, so I'll walk through all the steps that we laid out, and they're not necessarily sequential, or they don't have to be sequential, but it makes sense to follow it kind of sequentially in the way that we wrote about it. And so, first, you'd want to know that verticality or deficits in verticality are present in people who you would expect them to be deficient in. So, like, you could take a group of people who have had a stroke or Parkinson's or some other neurological pathology and measure this construct of verticality, and you should expect to see that verticality deficits in verticality is present in these people and not present in people who haven't had a stroke or who don't have Parkinson's, right? And that's the first key point of that Steve brought up, is like, what's the measurement of variability? How much, if everybody has a little bit of deficit in verticality, well, you need to quantify that and then determine that outside this normal range of variability and verticality, it's an impairment, and the people who have Parkinson's or have had a stroke have that characteristic about that. The second step would be, does the presence of deficits of verticality or dysfunctions in verticality predict some adverse outcomes? Or does it lead, presumably, to worse balance or falls? I assume that, that's the outcome of interest, is falls or less function. And so is this an important construct to identify? Right? And if it's not, if it has no relevance or no bearing on whether a person falls or not, it's good that you found it, but it's essentially less meaningful. So that would be like a next logical step to take. And these are all empirical questions that you can answer through study designs. Moving on to the treatment aspect, is verticality an important component of a treatment? Or really, does the presence of verticality in your patient influence the treatment that you select? In other words, do people who have deficits in verticality respond to a treatment differently than people who don't have deficits in verticality? And if you understand that, if you know that, then it helps guide your treatment selection. It's considered a treatment moderator. The presence of this deficit in verticality moderates your treatment effect, so that when you're deciding which treatment you choose for your patient, you need to consider the fact that the patient has a deficit in verticality. So it's very much a treatment focused question. And then the last part that we describe is the concept of mediation. So this is kind of a newer concept, but it's really important to understand if a change in verticality does in fact lead to a favorable outcome. And that's a question of treatment mechanism. So the standard randomized controlled trial that everybody knows about compares one treatment versus another on an outcome. So treatment A versus treatment B on an outcome of balance. The concept of mediation analysis helps you understand if treatment A outperformed treatment B on balance, is that outperformance due to a change in the verticality in the group who received treatment A compared to the group who received treatment B? Because if it is, then your treatments should focus on changing verticality. You should build treatments that emphasize changing verticality, because you know that that will maximize your treatment effects. So it's thought of as a way to decompose a treatment effect. And the way that it's done kind of mathematically, which helps me wrap my head around it, is if you have a treatment effect, and I'm going to shift back into, well, maybe I'll try to stay in neuro. I was going to shift back into my comfort zone in musculoskeletal, but I'll try to stay in neuro, right? So let's say there was a 1-point change in some outcome of balance, some balance score, the Berg balance scale, which that's the extent of my knowledge of balance scales. So let's say there was a 1-point change in the balance in the Berg balance scale in treatment A compared to treatment B. You can then decompose that 1 point and identify if a change in verticality is responsible and how much it's responsible for that 1-point treatment effect in balance. And you'd look at what's called an indirect effect. So you could quantify, say, a change in verticality led to a change in balance. How much of the change in balance is directly is influenced by the change in verticality? In other words, what proportion of the change in balance is mediated through this change in verticality? In other words, what is the treatment mechanism? Is the treatment mechanism for treatment A that has an effect on balance, does that go through a change in verticality? And you can quantify that and see if it's significant or not. And that's what a mediation analysis does. And then that gives you, again, a good justification for saying we need to identify, we know that verticality is present in people who have fall risk compared to others. We know that it has an influence on the treatment, and we know that if we change verticality, then we'll have a better treatment effect. And then you have a very solid justification for assessing verticality at the onset and creating a diagnosis of verticality because it's very clinically relevant. And so that's the process that we suggest, kind of the empirical process that we suggest takes place, not necessarily before we think verticality is a movement diagnosis, but with some, credibility towards verticality before you again implement this framework.
And even if you were to go through a mediator analysis and see if there's a change in verticality, it reduces the probability or number of falls. Is there still a chance that that change in verticality is not potentially that meaningful, or that's not the main thing?
Yeah, so it's a great question. So the way that this works from a study design is you at week 0 you provide you deliver your interventions and your control, and then at week 6, say, you measure your potential mediators, verticality, whatever else, strength, range of motion, some somatosensory, or whatever it may be, and then at week 12 you measure your outcome. And the key is that you're looking for a change in week 6 that preceded the change in the outcome at week 12. And certainly, something could have occurred before week 6 that is actually the key ingredient or the salient driver of the change. Or it could be not necessarily just verticality, it could be one of those other mediators, or it could be other unmeasured mediators. So certainly there's room for something that either precedes and it actually does explain the change that you didn't measure, or some other measurements that occur at week 6 but you just didn't take. Yeah. Steve, did I describe that? I'm interested to hear your input there if you feel like I described
No, I
that
think
well.
so. I think I was gonna move from the arcane to the slightly less arcane of mediation, and give a practical example from my own research experience, because I certainly don't want this to come across as we're throwing stones at glass houses. I've lived in this, not the movement system house, but I've lived in the psychologically informed care house. And one of the reasons I got interested in that is some of the early mediation type analyses showed pretty clearly that you could look at the change in, like, say, lumbar flexion, some of the key physical impairments, and you could also look at changes in pain catastrophizing, fear, and when you looked at these, it was actually, both are important, but some of the psychological factors, they were stronger mediators of clinical outcomes, like self-reported disability and reporting of pain intensity. So that was part of some of the earlier work that I got interested in. What then are things we can do as PTs to focus on changing the psychological variables? Where I have run into problems is they're consistent mediators, but what is hard is to find psychologic treatments that are better at mediating. So we have, in this case, we have a known mediator, but it's hard to find what are the types of treatments that actually take advantage of that mediation, if you will. So that's like another problem. But I don't want this to come across as we're asking people to do things that we haven't done or we're not aware of. So I thought a little background, to Chris's explanation of what you might expect to see in verticality. There have been some investigations done outside of the context of a movement system. And this is one of the great, for those who are interested in the psychological part, is we know it's an important mediator, but we don't necessarily know, what is the best way, which also provides some flexibility and freedom, because as long as you're addressing those factors, it doesn't seem like there's one way that is better than another. But I don't know if that example helps or not. But like I said, early in low back pain, when we had changes in physical impairment and changes in psychosocial variables, as a PT, of course, we're like, ooh, let's see which physical measure is correlated with the change in like a disability score. And it was correlated, but not as strongly with some of the psychosocial variables. And that's where we ended. And I think parallel work needs to be done with the movement system, because there are some things that people are really keen on measuring. And if they're strong mediators, we need to know that. And, but that needs to be shown empirically, and not just because, it was described somewhere and passed along, as part of a movement system examination or an assessment.
Towards the end of this section, Chris, you give the caveat that assuming that the larger effect in verticality intervention was caused by a change in verticality is false. Improvements in fall risk can be attributed to multitude of mechanisms. Do you want to discuss some of those mechanisms that could occur alongside the change in verticality, or maybe explain contributors to the change?
Yeah, I think it would be safer for me to just say that that you can't know that the mediator, you can't know that verticality was an important thing for you to measure at baseline and direct your treatment at, unless you measure it. Unless you measure it and you run that analysis. And I think I will go back to like my roots of musculoskeletal here. And if we designed a study where we thought strength, let's design a treatment that focuses on increasing back strength and measure our outcome of pain at 12 weeks and measure strength as a potential mediator at 6 weeks. Even if we designed the best strength program, and even if we had this phenomenal outcome of a decrease in pain, we cannot say that strengthening caused the decrease in pain. We can say that this treatment that was designed to increase strength caused a decrease in pain, but we can't say that actually getting stronger is what caused a decrease in pain until you perform that mediation analysis and see at 6 weeks, or whatever time frame it is, were people who were improving in pain getting stronger compared to people in the control group not improving in strength and not getting stronger, and not having the outcome at 12 weeks. It's a post hoc, that's what we talk about in the paper as a post hoc fallacy. It's very easy logically to make that assumption that if I design a treatment like a movement disorder based treatment and it has better outcomes than some other type of treatment, that's because I identified this movement disorder early on and my treatment changed this movement disorder, and therefore this movement disorder was a key focal aspect of my treatment, and it needs to be targeted, needs to be identified, needs to be targeted, we need to develop. That's seemingly is logical, but it's not. It's not true. It's a post hoc fallacy until you measure it and see that indeed that movement disorder changed in the people who experienced a positive outcome, didn't change in the people who didn't experience a positive outcome. That's the idea of a mediation effect.
Before we go into the more of these kind of orthopedic examples, I know you all started with the SIRD. Is there anything else, Chris, that you wanted to discuss in this kind of primary portion of the beginning of the paper that we didn't touch on?
I'll just reiterate that one point that I said, that we kind of based our argument on the assumption that you can measure the movement disorder reliably, that if all of us measured verticality or whatever movement disorder is, we'd all agree there. And that should precede a lot of the subsequent steps that we talked about. And that's a problem, more of a problem in the finite movement impairments, I think. If I think about like some of the really nitty, like subtalar joint assessments and SI joint assessments, when you start seeing some of the unreliability of those assessments, then it's like, well, how could we possibly ascribe, this thing that we can't even measure well to having some sort of importance on a treatment effect? And so it's like you're dead out of the gate right there, and it should be a full stop before you until you develop a solid, reliable assessment of whatever movement or dysfunction, whatever it may be, that you're trying to measure.
So, Steve, do you want to go into discussing some of these examples or these similar issues existing in musculoskeletal conditions? And maybe we start with SIRD, but I know you all used a variety of examples.
Yeah, and I think, we can, it may be interesting too to not spend a ton of time here and move to some of the moving forward, because I think, we kind of the spoiler alert for musculoskeletal is they should know better, I guess, is a good way to think of it. I feel like that was part of the reason why the neuro example was good, and kind of demonstrating what could be done, where musculoskeletal, we know what has been done. And as Chris mentioned, there's a lot of measurement error with some of these things, and that measurement error then confounds clinical decision making. If we're off to begin with on whether it's even there or not, that just kind of puts a lot of questions into anything that happens after that. And I think whether it's scapular upward rotation, whether it's some of the sacroiliac joints, static or dynamic, that there's a theme there that that the clinical interpretation that we value and we train each other on, and our students, that actually breeds some of the measurement error too. And that until that is reconciled, it's hard to widely recommend assessment in this manner. I think back to one of the more impressionable things I saw early in my career. Tim Flynn, who I think is still a household name in PT. Some of the work that they were doing before a clinical prediction rule was developed, and independent of what you think about clinical prediction rules, this isn't relevant, but they did a study where they had people that were positive, negative on every sacroiliac joint test that you could imagine. Some were static, some were dynamic, some have been recommended, still. And they had yes or no for like a good clinical outcome. And it was, the thinking, I was in my manual therapy training, is the people who are positive on those tests are going to benefit more from manual therapy than the people who are negative. Does that make sense? If we find that you have, whatever it is, and I'm going to do something to counter that, whatever it is, that should be better. And there was no difference in disability or pain scores, whether you're positive or negative on that test. And the thing I liked about that table is often when people do research, they're like, well, they didn't use my test. Like that, my movement test wasn't in there, or my sacroiliac test wasn't in there. Well, this had them all. And there wasn't even a type 1 error. There wasn't even an exact accidental difference. I mean, people improved regardless of their, what their test result was. And whether that's because there's a lot of error or the test result doesn't matter, that's a more nuanced study design. But the bottom line was, it did not have that predictive validity component that we talked about earlier. And, I saw that early enough. And I know there was a lot of other work that came from that, but that was a very early look. And that's frankly why things like clinical prediction rules had included things outside of what at the time a lot of manual therapists were using. What was it, the supine to sit test we used to do, those things that were supposed to be proxy measures of either movement or positional things. And that, to me, it's only one table and one paper, but when I saw that, my clinical brain and my research brain, unbeknownst to me, that was one of the times they kind of merged. And I was thinking, this table says a lot, and what it says is I may want to use these tests to decide if I'm going to do manual therapy or not, but I better not confuse that with this person's going to do better from the manual therapy. And that's a little bit of what Chris was talking about earlier with some of the fallacy. I should not think the reason they got better with the treatment I chose was because the result of the test. And that table showed it pretty clearly. Does that make sense, or is that too? And again, Chris, the not the Chris Joyce, Chris Hughes. The if you if there's a specific example we can go into, but I think for me the big picture with musculoskeletal is we know quite a bit, and maybe we should focus in on less is more. Where are the areas where there's promise to for movement, and not necessarily think it has to be everything that is being advocated for. And we picked on Surd just because I mean, there's a lot of easy ones, frankly, to pick on, but that was one that was, I don't know if that was in the original or what, but that was one where it's hard to advocate scientifically for that one, in our opinion.
Yeah, we chose it because I think it's the example. So the current movement right now is for the APTA to solicit these diagnoses from clinicians and researchers, and they provided an example of one, and the example that they used, I think, is scapular upward rotation deficits. And again, when we in the paper we go through like it's a bit, it's a bit tenuous, the relationship between this and pain and disability, and it's even, it's arguably dead out of the gate in that people don't even agree on its measurements, properties of validity and reliability. So that's why we went with CERD. Yeah.
Yeah, that makes sense. And Steve, to your point, I don't think we need to touch on a ton of others, but you all briefly discuss like knee valgus or shoulder position or resting posture, et cetera, whatever it is. It's the similar examples of, can it be reliably measured, and does it need to be changed, and is it valuable, and does it change outcomes, et cetera. So to the moving forward portion, the part one of moving forward, shifting away from diagnostic labels. Chris, do you want to start with why there should be a shift away from diagnostic labels?
Yeah. So some of the arguments that we make, and we don't spend a lot of time here, but conceptually, we think that patients do want to know a diagnosis, but they care more about what's my prognosis? How am I going to do with this? What does this mean? And um, we have a lot of good studies and some evidence that there's lots of variables that influence a prognosis outside of just biomechanics. And if we spend so much time emphasizing this detailed assessments on movement impairments, then we risk missing the more important prognostic factors, such as psychological aspects and traits, or certainly sociological aspects and traits. And um, so that's kind of like one of the points that we try to bring up, is that we think patients care more about prognosis, and we think there's more evidence supporting the identification of prognostic factors and the integration of prognostic factors into treatment as being more meaningful and more important. So that's one aspect. The second one is that overdiagnosis has been associated with over medicalization in over utilization. And so that's definitely a concern. And essentially what that boils down to is if you're over assessing, or if you're over diagnosing, if you're finding lots of things on people, you're more likely to provide treatment for these things. You're more likely or you have more potential to create something out of nothing. Something that's just normal variability now becomes pathological or pathologicized, and that leads to treatment and unnecessary care. And so we see relevance in that again, and it kind of goes back to, well, if everybody moves kind of differently, then you don't need to necessarily measure these differences. You don't need to necessarily assess and ascribe a diagnosis to these differences, because it's just normal. And there's no reason to focus your assessment on that, because it could lead to unnecessary and unwarranted treatment. And we know that tremendous treatment variability exists in physical therapy, and perhaps that's due to everybody looking at things differently and everybody overemphasizing things that are largely potentially irrelevant. for a strong outcome. I always think of the example, and I kind of had this conversation with somebody on Facebook, like if I have shoulder pain putting my kid into my car, um, which is a really complex movement, do you think it's really necessary to identify every joint motion, every muscle length, every muscle strength to tell me why my shoulder hurts putting my kid into my car? Or should we just focus on the task of putting my kid into my car, and maybe that can make it easier? Or is it that my kid is just a maniac when I try to put him into the car? Maybe it's the kid that needs some behavioral interventions, or maybe it's that it only hurts when I'm stressed out at the end of the day. And that's really what's leading to my pain. Or maybe it's that my car seat is old and my car is old and it doesn't work that well, and there's other, and I can't afford to get a different car seat or a different car that would be easier for me to put my kid into. And if I just had that, then I wouldn't have shoulder pain. And so it becomes, I use the term myopic or reductionist if we just think that a movement and pain with movement can be so simply reduced to the way a muscle, the position of a joint, or the arthrokinematics of a joint or a muscle, or a muscle strength, length, or whatever it may be. And we know better than that we know that movement and pain is much more complex and dynamic, and there's so many factors that influence pain. And so that was really like when we saw this, again, this diagnosis template go out, and this emphasis on pathokinesiology and kinesiopathology. I forget which one's which sometimes. That's really where we were like, whoa, like this is too simplified. This is a step in the wrong direction, that we think.
And the only thing I'd add is this is consistent, with other areas. Again, we don't want to pick on people or unnecessarily, but I do worry a little bit about labels. First of all, with this much error associated with them, and second of all, with producing potential stigma of being labeled. When I taught EVP, one of my favorite kind of Sackett quotes was the quote about, as soon as you label someone, and I don't remember it right off the top of my head, but basically they're sick or longer as soon as you diagnose this. So you better be sure when you diagnose someone that comes, and it's with some options for treatment, that there's some benefit. Otherwise, they're just experiencing symptoms. And I think of that with the movement system is, are we prepared to say someone is not moving optimally or the way they should? Are we prepared to give that label with all the consequences that come with it? And, this has been known for some time in back pain now, but you're starting to see more and more the next one that's kind of on the hit list, and it's not exactly movement related, but it's close, is this bone on bone label. There's a lot of interest now in OA, especially with knee. Like, what are the consequences when you tell someone they have bone on bone and just leave it like that? Because there's a lot of people that have bone on bone that don't have a lot of pain and don't have a lot of limitation, and that's the message they get, and it kind of leaves them hanging, because the implication is you're screwed. But we know there are some people that are quite capable, with having bone on bone, and even that there's variability of what that label means. And I think, with the movement labels, it's much, much more nuanced than that, because that's just based on a radiographic read. So I worry a little bit about the consequences of labeling when we don't have it clearly, have it all lined up. What can we do now that we've labeled you? What can we do? And does it really matter that we labeled you, in the big picture of things?
And Alan Jetty wrote a nice editorial. I think it's called "The Paradox of Physical Therapy," and he says, if we label things normal, then that means we label things abnormal, and that means that we put labels on a lot of, and that means that, and then we make the association between abnormality and disability, and that's a problem because disability is a social construct and abnormality is a personal construct. So you're saying your disability is due to your abnormality, and that's that's again a gross simplification, because disability is a social construct, and so we're not as Steve said, by labeling somebody, there's this implicit um, assumption in here that the cause of your disability is due to your abnormality, and that's not it's not a good road, I think, to go down. I think Alan brings up a lot of good points in that paper. It's on the verge of ostracizing people who just move differently. So another cautionary tale there.
So, what are better options as a day-to-day physical therapist if we're saying that there's these wide variations of human movement and there's all these other contextual factors and psychosocial factors, and we can't really put people in a movement box or shame them for something that is quote unquote out of the box? What is important and meaningful, and how do we move out of this kind of movement diagnosis paradigm?
Well, I mean, there are existing paradigms, and again, I don't think there's anything that we are. I think it's more the wholesale adoption, of this, or kind of there's some cart before horse issues with this. I don't think. I mean, I think Chris and I both would be happy being wrong in 10 or 15 years, and maybe the movement system is the way to go. I also pretty, confident about where we sit with that. So I think there are some options. One, I think, would be there's a difference between documenting movement variability and labeling it. I think that's one mindset I would get into is, I think also this lends itself more to seeing where things converge and diverge instead of like pinpointing on 4 or 5 things. One of the things, so again, so part of this reminds me of, and I don't know if this is a good example or not, but it's the one I'm going to use. Back in the day, non-organic signs, right, were ways to capture malingering. Well, we found out 2 things. One, they don't, and we don't even know what malingering is. So I feel like we have a list now of movement system things that could identify something, but we don't know if it exists or if it even matters. I mean, all we learned from the non-organic signs lesson was that when people are in pain and seeking care, they're going to let you know. Like that's called magnified illness behavior now, but it is, if this person has back pain or neck pain and there's no diagnostic test that can find it, of course they're going to tell you it hurts when you push here or there, because that's the only way we've given them to validate it. So I think the linkage there is we need to give it some time, but there is some value in documenting how people respond to things and what that variability is. And then I think be aware that the patient goals for movement might be very different than our goals for movement. And I think that's another thing that, is really important. And that kind of gets to Chris's example of the car seat. And then I think the last thing, which was right on the tip of my tongue, it might take me a second to, don't confound movement and behavior. Behavior, I think of movement as what they're doing in front of you in the clinic, and behavior is what they do in the wild. And don't think that what you're observing in the clinic is exactly the same as what is going to happen in the free. So I'm sorry, I know you probably wanted a checklist or, a clinical decision support tool, but I think it's more, let's collect some information on this. Let's use it maybe as an adjunct to what you're doing right now, but let's test it out a little bit. I mean, let's see. I just think there's so much variability in this that, it's going to be hard to tease out. I use my lessons learned from being a pain researcher and what we experienced when we started doing quantitative sensory testing, and all we learned is there's no wrong response to a stimuli when you ask someone if it hurts, because everyone can use the entire range. And I wonder if it's kind of like that with movement. Like there's probably such a wide range of acceptable variability that it might be hard for us to identify ranges that we're really truly concerned about. So I'm sorry if that was abstract, but that's, um, I, I encourage people to collect information on it, but where I'm less excited is drawing lines and saying this is good and bad, this is right and wrong, this is optimal, this is not optimal. But collect it and let's see how it pans out.
Chris, do you have any thoughts there?
Yeah, I have the same problem. Like, I don't think there's an easy answer to this. I think it's a step back first and to say to ourselves, would would we be better off just looking at the movement that the person wants to accomplish, thinking about that movement in the context in which in the environment that they want to accomplish that movement in, breaking down that movement into smaller pieces and just working that way. It's a very simple way of thinking about movement while also measuring and or at least getting an idea of some of the other important factors like their fear avoidance, their self-efficacy, and then certainly some of the social determinants that are influencing that could be really influential for their treatment and outcome. So when it comes to improving movement, I don't think, let me see if I can get this right. I don't think the sum equals the whole. I don't think, and I think that's the approach that we take as PTs. It's like um, the sum of parts is greater than the whole or is equal to the whole or whatever that saying is maybe. The whole is the whole, and just focus on the whole instead of dissecting into all these potentially irrelevant parts, and you might end up with a better outcome. And then sweating some of the other bigger stuff, where, like we said, some of the psychosocial determinants that we know are key prognostic indicators for outcomes.
Sweating some of the bigger stuff like what you just mentioned, how can we have an effect on that as physical therapists? What would that even look like?
It's great. It's another great question. I think Steve mentioned that, like, we know that low self-efficacy or pain catastrophes or fear avoidance are important potential mediators for outcomes in people who have low back pain, but we don't know how to improve those things. We don't really know that much how to improve people who do have chronic low back pain. Um, so I think that's the future research. And then as far as like the social determinants, I think that a lot of people are publishing in PTJ about how important it is and how to integrate this stuff. I don't think there's solutions yet, but it's awareness and it's recognizing that these things are important, and probably better integration with other healthcare providers and social support services would be, a low hanging fruit, at least to start with. Yeah.
Wrapping up here, if y'all were teaching this to the students in your PT programs or to new clinicians, and they were reading this article and maybe they kind of get lost in some of the weeds of some of the first portion of verticality and trying to like piece together validity and reliability and all mediator moderator analysis, what would you say big picture takeaways are moving forward for these students or new clinicians of what they can feel optimistic about moving forward and maybe some things that they should reconsider?
I teach a lot of this in one of my courses about like logical clinical reasoning process, and I think the students really grasp it when you start at the end and you think about and I'll use manual therapy because that's the example that I'm most comfortable with. But does manual therapy have an effect on um, pain due to changes in biomechanical movements, which has long been thought of as the reason that manual therapy does. So it's like our biomechanical changes, mediators of improvements in pain due to manual therapy. And if when you start with that and then work back, you have to the first question that innately comes up is, can we measure these biomechanical um, movements? And if we can't, then we can't ascribe manual therapy as treating or as improving pain through those biomechanical impairments. And so that's like the first step. And so just take that lens for all the things that you think about when you apply a treatment. People want, PTs love treatments. When you apply a treatment, ask yourself two questions. The first question is, what do I think I'm doing with this treatment? Why is this treatment having the effect on the outcome that I want? And usually, it's pain, but maybe it's balance, maybe it's disability, maybe it's something else or function. Why do I think this treatment is having that effect? And then the second question is, what would I have to do to know that that is true? And just from a conceptual standpoint, what would I have to do? And people, I think that's pretty digestible. And then if you really want to go into the weeds, then think about, well, if I wanted to try to know that this thought is true, I'd have to be able to measure this thing, and then I'd have to know that I could change this thing. Then I would have to see this change as a result of my treatment. Then I would have to see that this change leads to the outcome that I want. And if you take that, I think that is, to me, is like critical thinking. If you take that approach with all the treatments that you use, you might just start questioning why you're doing it. And it might open up your eyes to, well, I mean, maybe there's other reasons why my treatments are helpful. Maybe it doesn't matter. This treatment is still helpful, but I'm not, at the very least, I'm not going to say stuff that's not logical. I'm not going to say I'm doing this treatment to you because it changes X, Y, and Z, because frankly, I have no idea if it changes X, Y, and Z. Like, that would be a great place to start kind of like de-implementing some of the prior beliefs about mechanisms of treatments. And you could probably do that for a ton of treatments that we use in PT. But it's a good question.
Yeah, I think that makes a lot of sense. We're pulling back and thinking, if there's a positive effect, is it for the reason I believe? And what are all the other potential mechanisms or considerations or contributors? And if I were to do something else or not do anything at all, would I have similar outcomes? And then how am I framing this to the patient? I think that's great. Steve, what are your thoughts?
Yeah, I'll be a little more concise. No offense to Chris. I would do very similar advice to what I give people, anytime with this. It's pick one or two of these things that you think have the highest relevance and use it in your clinic for a year. Use it on everyone. Try to get, if it's a test, try to collect it on everyone and, see what you learn from it. And, prove us wrong. Like, pick out something if that, and because I don't think anything is entirely wrong or right about anything that we've talked about. It's just about gathering the information, and I think you can't do it all, so pick the one or two that you want to do, but you have to do it consistently in your clinic. And what I have found is, when you start doing, like, if you do the same thing, same assessment, and everyone, you start getting appreciation for the variability that is there. And if that's a lesson you learn, it's a great one to learn, because I think sometimes our memory is a little tricky. We like to remember things that make sense to us. But if you start doing, verticality or whichever we talked about, if you do a upward rotation test on everyone, you might start looking at it a little bit differently. So that would be mine: is pick something, stick with it for a year, document it, and then go back and look at it, and almost like a QI type of project. And I think you can learn a lot from that.
Any other final thoughts? I think that may be a perfect place to wrap it up.
No, thanks for the chance to explain a little bit more. I know Chris Joyce has been active and social media. So thanks for answering, all of those. But I enjoyed working with Chris putting it together, and I think hopefully it'll give some people some things to think about, and again, not just see it as an exercise of throwing stones, but actually, like I said, I think there's some playbook material there for people to think about moving forward. It's surprising how many times researchers repeat mistakes from the past, and there's enough, I think, especially in musculoskeletal, like don't repeat these mistakes. If you want to advocate for the system, think of different ways to test these, because some of the early work, just has not been supportive.
Awesome. We'll call it there. Chris, Steve, thank you all so much. And thanks to Jason, who we had to kick out of the call, or he volunteered. Yeah, appreciate y'all and all the work you do, not just this paper, but teaching students, publishing, etc. Thanks again.
Thanks for having us, Chris.